Welcome everyone to the SAV's April educational webinar, Management of Malignant Pleural Effusions in 2023 with Dr. Kat Oberg. As a reminder to anyone who's new here to the SAV webinars, you all have joined in a listen-only mode. You may submit all your questions that you have through your control panel. You also may use the chat feature to submit your questions. We will address them at the end of Dr. Oberg's lecture. At this time, I will introduce Dr. Bawadam, who works alongside the SAB on our Education and Program Committee, and he will be moderating tonight's session. Dr. Bawadam.
Hello, everybody, and good evening. My name is Hasnain Bawadam, and I'm a board-certified interventional pulmonologist at Advocate Aurora Kenosha Center and member of the Education Committee for the Society of Advanced Bronchoscopy. It's an honor for me this evening to introduce Catherine Oberg. She's an interventional board-certified member of the American College Association of Bronchology and Interventional Pulmonology, fellowship completed at Harvard Combined Program, and board-certified in critical care medicine with a fellowship from the Icahn School of Medicine at Mount Sinai. She's currently an assistant professor of clinical medicine at the David Geffen School of Medicine at UCLA, in addition to being the associate program director for their IP fellowship program. She has had multiple publications and book chapters she has authored. She has several academic publications and laurels to her credit. She has served as AABIP as an invited speaker for the National Board Review course. She has been voted in both 2022 and 2023 as a Super Doctors Rising Star, which is only the top 2.5% of the doctors in Southern California. So without delay, I hand over to Catherine Oberg, who has an excellent talk planned for us.
Thank you so much. I think that's the warmest welcome that I have ever had, and I appreciate it. I'm really excited to be here with you guys. I'm sorry about my camera. My Mac seems to be having an issue, so you'll just be stuck with my voice, but that's probably fine. So I'm excited to talk about this, the management of malignant pleural effusions, because there's been so much that has happened over time and in the last several years that I think it's a great thing for us to all try and stay up to date about. This is my disclosure slide, and I know for the guidelines, I need to leave this on for several seconds. So I am a scientific consultant for the companies listed here: Medtronic, Intuitive, Noah Medical, Boston Scientific, and Nuance. I was the site PI for the Lung Therapeutics fibrinolytic trial, which was a pleural trial. It was for infected pleural spaces, so it doesn't relate to this lecture, nor do any of my roles for the other companies. So the mandatory disclaimer: I am the presenter and this content is all mine. Let's get started. So I'm going to set the stage for us, and then we're going to jump into, I think the first question that a lot of people get now is that with all these advances in targeted therapy for lung cancer and other cancers, are we even needed in the world of pleural effusions? You know, now that people get early targeted therapy, does that just zap the effusion and we're all fine? If so, this would be a 5-minute talk. So the answer is no, but once we go through some of the data, and there is data, then we'll jump into what were some of the formative studies in the world of pleurodesis and tunneled pleural catheters, and then what do we have that's new and changing our approach to things. We'll talk about combined approaches of the two things. We'll talk about how cost factors in, because it does for us and our patients in the healthcare system. And one thing that always comes into play is how good are we at actually prognosticating survival for patients with malignant pleural effusions, because we talk about this when we talk about cost and other things. And then I'll sort of wrap it up and then take questions afterwards. So we're talking about malignant pleural effusions, which by definition is infiltration of cancer cells into the pleural tissue. And you have malignant cells on pleural biopsy or pleural fluid. It's different from a paramalignant effusion, where this is still related to tumor, but the tumor effect on the pleura is indirect. It's not direct infiltration of cells. It's that you have an effusion built up because of airway obstruction or SVC syndrome or something like that, and the pleural fluid and biopsy is actually negative for malignant cells. And in the trials that I'm going to talk about, the majority are, truly diagnosed malignant effusions, although some trials will have suspected malignant effusions as well, which could actually be paramalignant. The scope of pleural disease and malignant pleural effusion is huge. We know that it's over 125,000 hospital admissions per year in the US alone. We know that inpatient costs are over $5 billion per year. The average survival in general is not good. Of course, it depends on the stage and the type of malignancy, and lymphoma, as an example, is an exception. And some of the things we're going to talk about is, as survival is increasing for cancer patients, what does that look like in the world of pleural effusions? But regardless, the one thing that hasn't changed is that pleural effusions have a significant impact on symptoms, on quality of life for our patients, and can be quite challenging to manage. So I like to start and frame this by, I think the most important thing to talk about is endpoints that matter. And we have, thankfully, trials that have done this in various ways. Things like symptom control, things like how much time are people having to spend in the hospital, how many additional procedures do they have to have after whatever their sort of initial management procedure is, what is the cost for all of these things and all the downstream effects when they have complications and whatnot. All of these things are things that matter to us and our patients in the healthcare system. So the first thing I'll talk about is the effective targeted therapies, because this is the big thing in the world of lung cancer and other cancers. On the left side, I just like this diagram showing all of the targeted mutations that are out there. And this is not just for lung cancer, but for other cancers that thankfully we are developing every day targeted therapies for. And you can see these targeted therapies on the right side. This is for lung cancer now specifically, and the different mutations that are out there and the targeted therapies that are available. And so oftentimes I hear, hey, this person has an EGFR mutation. We're going to start them on this targeted therapy. So let's not worry about the pleural effusion. We're going to start them on therapy right away, and that'll take care of it. And that's where I think some of these trials recently have been really helpful in providing some clarity with that. This first study I want to talk about was published at the end of 2021 in CHEST, and it was a retrospective analysis, but of prospective data, looking at a cohort of patients with malignant pleural effusion from lung, breast, ovarian, and hematologic malignancies. So this was a mixed bag. They collected data for almost 10 years, and they were really looking at resolution of the malignant pleural effusion, and I put the definition of resolution here, and they were looking at it in a stratified way of cancers that they deemed pharmacologically sensitive, meaning things like lymphoma, small cell, mutation positive lung cancer, things that are going to respond to therapy, and then non-sensitive tumors, which was everything else. And then they also looked at within each of these categories with systemic anti-cancer treatment and without, and then looked at resolution of the pleural effusions. So they had 280 patients overall. A little less than half had what they deemed sensitive tumors, a little over half had non-sensitive, and then within this, more received systemic anti-cancer therapy rather than not. And this is what they found, and I think this is the most important point and was their primary endpoint, is when they were looking at malignant pleural effusion resolution, you can see the p-values here for each of these entities. For whether the tumor was sensitive to therapy or not, and whether they received treatment or not, there was actually no difference in pleural effusion resolution. The only thing they found to actually be related to resolution is here with the hematologic cancers, so things like lymphoma, which makes sense clinically. And then, people who had chemical pleurodesis achieved effusion resolution sooner, which I think also intuitively makes sense. And so their ultimate conclusion is that patients who have a symptomatic malignant pleural effusions should still receive early intervention, whether or not the tumor is sensitive or not, kind of regardless of their treatment options. This was also looked at with Audra Schwach and the ND Anderson group and published in Chest in 2021. And now this cohort was specifically patients with metastatic lung cancer, non-small cell. And they followed these patients from the time of their initial drainage up until recurrence, ipsilateral recurrence of that effusion that required intervention. They had almost 400 patients. About 3/4 of them did not have actionable mutations and about 1/4 did. And of those who had an actionable mutation, 90% received that targeted therapy within a month of the thoracentesis. And you can see here, this is stratifying by, in the red or kind of pink, patients who had no mutations, and then in the blue, patients who did have a mutation, and the time to pleural effusion recurrence. And actually those in the group that had a mutation had a higher recurrence rate than those who didn't. They also looked at other data points and found that patients with larger pleural effusions, higher levels of LDH, and positive cytology results had a higher likelihood of pleural fluid recurrence. So they had a similar conclusion now for patients specifically with advanced lung cancer, is that these patients, if they have a large effusion, they have a high probability of recurrence regardless of mutation status. In 2020 in respirology, now kind of another spin on it, sort of the next step, if you will, this was looking at lung cancer patients with malignant pleural effusion, but this time they looked at actually early malignant pleural effusion intervention. And this was not a randomized prospective trial, but they divided this up. Of the 233 patients in this cohort, of note, 93% of these are lung adenocarcinoma, so that's important. But in that 233N, about half of them had actionable mutations and oral targeted therapy as the first line treatment. And so then in this diagram, you can see now we're looking at the 127 people who have driver mutations. They divided this up into those who had early pleural fluid control of some type versus those who did not before they started the targeted therapy. And then they looked to see who required re-intervention and who didn't in both groups. And you can see that they found that there were significantly lower re-intervention rates in the early pleural fluid intervention group rather than the group that didn't have intervention. And it was significant, 23.5% re-intervention versus over half who required re-intervention if they didn't receive this early pleural fluid intervention. And so their conclusion was that the adoption of early effusion control measures, especially in lung cancer, should be considered sort of regardless of the anti-cancer management strategy. So I think these are really informative studies and help us then with our approach, because now we know that even if they have targeted mutations and therapies, we're still going to have to do something about the effusion. And so I think everybody has their version of this flow chart. And, the limitations with algorithms is that patients are patients, they're individuals, and they don't all fall into algorithms. But I use this as a general framework about how I think about these patients. And so when we're talking about patients who have a recurrent symptomatic malignant effusion, the first thing is, do they get relief with pleural drainage? And if they don't, then we need to be thinking about other things, about why they're dyspneic or how to treat it. If they do, then it's a discussion with the patient about the goals, the risks, the benefits. And a lot that goes into this sort of informed conversation is what we're going to talk about, the evidence that we have to help us with this in the coming slides. But in general, the options are, intermittent thoracenteses, and then depending on if they have a trapped lung or not. If they don't, do we want to take them to thoracoscopy? Do we want to do pleurodesis or a rapid pleurodesis protocol? Or if they can't tolerate it or they have a trapped lung, then we're talking about tunnel pleural catheter placement. If they don't have a trapped lung, but they don't want thoracoscopy, do we put in a TPC, and then do we do a TOG slurry? All of these things are the options that are out there. And thankfully, we actually have a lot of data to sort of inform our conversations when we have these with patients. The other important part of this, and this is really more of a focus on therapeutic management, but I had to put this in there at the bottom, that the question of, is more tissue or fluid needed, either for diagnosis or for molecular markers or what have you, because that will often inform my decision making and the conversation I have with the patient about both sort of diagnostic and therapeutic management. So I just have a slide or two about this part because I do think it integrates into the conversation about therapeutic management, about is more tissue needed. Now this is, my talk is management in 2023, right? And I'm showing you a paper from 1983. I love it because they had a large N. They looked at the yield for malignancy for needle biopsy, cytology, and pleural biopsies by thoracoscopy. They looked at them separately, they looked at them together, and ultimately found that pleural biopsies by thoracoscopy have a much higher yield for malignancy than cytology or blind needle biopsies. So these were blind biopsies. These weren't ultrasound guided or CT guided. So this is 1983. Now, flash forward to 2019, and this study that came out of the Annals of the ATS, where they reviewed data looking at many things, but one of them was the diagnostic modality. And you can see here that that study from the 80s still holds true in a way. Cytology is the lowest yield, blind needle biopsy is not that much better. Ultrasound and CT guided pleural biopsies are getting better, and then medical or surgical thoracoscopic pleural biopsies are the highest. So not a lot has changed in that, although we are going to talk about something towards the end of the talk where maybe type of tumor influences this. As far as yield from molecular markers, there haven't been a ton of studies out there about this, surprisingly. However, this is a study that was published as an abstract at the ERS last year in 2022, and I like it a lot. It's 4 sites, 3 countries, and an N of almost 200 patients, 184 patients, and they're looking at the yield of different types of pleural biopsies for molecular markers in lung cancer. So 57% of the cohort had a pleural biopsy by thoracoscopy, about a third had an ultrasound guided pleural biopsy, and 7% had a CT guided biopsy. And about half the patients, or a little over, had lung cancer, and 19% had breast, and the remainder was sort of a mix. And what they found is that the mode of biopsy does influence the yield of molecular testing. So they found that thoracoscopic pleural biopsies had the highest yield at 95%, CT guided not too far behind at 86%, and then ultrasound guided 76%. And they also found that the size of the biopsy mattered. If it was above 2 centimeters, then 100% of the time they got the diagnosis, which may be why thoracoscopy seems to be better for getting molecular testing. But that's all I'll say about the diagnostic portion. But when I sort of wrap things up, again, this informs my decisions about how I'm also going to therapeutically manage someone. Because at the end of the day, I want to do, the least amount of things to people necessary. And if they need multiple things and we can do them at the same time, then so much the better. So now I'll talk about pleurodesis. And we're very familiar, I think, with what this is. The word pleurodesis comes from the Greek words of pleura and desmos, meaning pleura and bond. This is fusion of the parietal and visceral pleura, which is why patients with trapped lung don't pleurodese, because you can't fuse the parietal and visceral pleura. And there are options that are mechanical or chemical. And actually, when I was going through and putting this talk together, the first pleurodesis was performed in 1901. So I went down a bit of a rabbit hole looking at the papers from 1901 and 1906. And I won't burden you guys with that, but I did not realize that pleurodesis goes back quite so far. The way that it works is that you have an agent that and I just want to make sure here, yes. You have an agent that you instill into the pleural space. It's an irritant. Here it's showing talc. This irritant irritates, of course, the mesothelial cells and causes mesothelial injury. This then triggers this inflammatory cascade, and it triggers things like TGF-beta and IL-8 to again go through the inflammatory process and then ultimately triggering the fibrotic process, which is what helps fuse the pleural membranes together. There are other pathways that happen when you introduce an irritant like talc and again start to cause mesothelial injury. It also triggers the coagulation cascade, which then ultimately leads to fibrosis as well. here we go. This is the slide that I thought was before that, so I apologize. There are several different agents that have been used for pleurodesis. Things like bleomycin, doxycycline, tetracycline, same family, talc, and povidone iodine. And talc is really the best studied of all of these. So a lot of the studies that I'll talk about moving forward are talc-based studies. Complications of pleurodesis range. Chest pain is common, pain in general is common, fever post-pleurodesis is common, and a big thing that gets brought up, and especially because talc is so widely used, is what about the association between talc and ARDS? So there are two proposed mechanisms by which talc particles migrate and cause systematic issues. And one is that maybe they're lymphatically absorbed, and otherwise maybe they induce changes in the alveolar capillary membrane permeability, which then leads to ARDS. And so when this was being researched, ultimately we kind of figured out that the smaller the talc particles are, the higher the likelihood of ARDS. And this led to sort of the development or the use of graded talc. And graded just means that the powder's processed to filter to a certain particle size. And there have been several studies showing that ARDS did occur with smaller particle size, and many large series showing no cases of ARDS once you're using the larger sized or graded talc. So that's something that gets brought up a lot, and I wanted to make sure that I just addressed it at least on one slide. Clinical outcomes with pleurodesis, of course, are things that we care about. This is a meta-analysis that was published in 2014 looking at over 1,500 patients. And this is probably the most comprehensive, being a meta-analysis looking at different agents of pleurodesis, because really there aren't a lot of large trials comparing pleurodesis agents to each other. And this is what they found in this meta-analysis, is that talc versus bleomycin, the talc wins. In studies even going back from the 80s into the 2000s, talc is superior to bleomycin, seemingly for pleurodesis. However, of the studies, of which there are not a lot, talc versus tetracycline and talc versus iodine, they could not detect a difference. Although you can see in this chart here that there are only 2 studies in each of those comparators. So again, I think this speaks more to the paucity of evidence looking at talc, head to head compared to other pleurodesis agents. But in general, this is what we have. So when, again, and moving forward, most of these studies are talking about talc. When we're going to do a talc pleurodesis, which is the best way? Is it poudrage, meaning that we're spraying this during thoracoscopy, or is it a slurry mixed with saline that we're putting through a chest tube? And this has been a subject of a lot of debate and study about which one is better. So I think, one of the foundational studies in this is from CHEST in 2005, where they randomized patients to either talc poudrage or talc slurry. And you can see what the definition of poudrage and slurry are here, but it's 4 to 5 grams of talc. And the outcomes that they looked at were the percent of patients whose lung initially re-expanded greater than 90% and who had a successful pleurodesis at 30 days. And this is what they found. You can see the 2 lines almost completely overlap between slurry and insufflation, meaning poudrage. So overall, they found no difference in the groups. Poudrage maybe slightly ahead at 78% and versus slurry 71%, but that was not statistically different. However, when they did some subgroup analyses, they did find that patients with primary lung or breast cancer had higher success with poudrage than slurry. So this was one of, again, I think the foundational studies here. Now, fast forward 15 years, and now we're in 2020. A study came out in JAMA looking at this same concept. And this was a randomized controlled trial that was published out of the UK, and it included 17 centers in the UK. And the poudrage group had 4 grams of talc under thoracoscopy, and the control group had bedside chest tube placement and then 4 grams of talc placed by slurry. And their primary outcome was looking at pleurodesis failure at 90 days. And here again, you can see that when they're looking at, from 30 all the way up to 180 days after randomization, the lines differ a bit, but really it doesn't look like there's a lot of difference in the talc slurry and the talc poudrage group. And that's what they found, actually, is that 22% of patients had pleurodesis failure at 90 days in the Pudrage group, 24% in the slurry group. So ultimately, they concluded that among patients with malignant pleural effusions, Pudrage compared to slurry had no difference in pleurodesis failure rates at 90 days. They were equally as good or as bad. I had to say equally as good. What about novel agents? Because we've talked about things like bleomycin and talc, and is talc just what we're going to be using forever, and that's it? No, of course. There's a body of literature looking at various novel agents that I wanted to include. Going back to the ERJ in 2003, there was a study looking at TGF-beta. And if you remember, that was part of that pathway that talc, once it causes the mesothelial injury, then induces TGF-beta, IL-8. So this is a study where they actually, applied TGF-beta, talc, and doxycycline separately to rabbit mesothelial cells. And then they also injected them intrapleurally in the rabbits. And then afterwards, they collected pleural fluid and measured IL-8 levels. And you can see here in both the talc and the doxycycline groups that the IL-8 dramatically increased with the larger amount of talc or doxycycline they put in, meaning that the inflammation increased. Whereas if they just put in TGF-beta alone, you can see that the levels of IL-8 were pretty much the same. So the thought here is that, hey, maybe if we just skip right to the TGF-beta part, we can induce that fibrosis without causing inflammation and pain and everything that comes with that. Similarly, people have looked at fibrin or fibrin tissue adhesives as pleurodesis agents. This is a study, back from the mid-2000s looking at fibrin tissue adhesives and injecting these into the pleura in rats to see, compared to tetracycline and control, what their outcomes were. And here they were looking at adhesion, so adhesion formation in the pleura, adhesion scores. And you can see here that the fibrin glue, the group 1, which is the fibrinogen and factor 13, had a significantly higher amount of adhesions compared to control and tetracycline and the other type of fibrin glue, actually, which was thrombin based. So ultimately, they concluded that when compared to these other pleurodesis agents, there was more adhesion and less inflammation with fibrin. Now, flash forward 11 years, and a study published in Chest in 2016 also looking at fibrin sealant, but with a few other things. So in this study, they had rabbits where they either had VATS alone, or they had VATS with gauze abrasion, abrasion plus fibrin, or apical pleurectomy. So there were several different groups, and they collected blood beforehand and afterhand and looked at things like white count and neutrophil count and IL-8 again. And then at 28 days, they were sacrificed, and they were looking for macroscopic changes like apical pleurodesis, and then microscopic things like pleural fibrosis and collagen development. And you can see here in the groups that the abrasion and the fibrin sealant, as well as the pleurectomy, had the highest likelihood of causing adhesions, and they were equal amongst the two. Similarly, with causing fibrosis, there was no statistically significant difference between the abrasion and sealant, the fibrin, versus pleurectomy and causing fibrosis, but they were higher than abrasion or control alone. And when they looked at IL-8 levels, they saw that in the control, abrasion, and the abrasion and fibrin group, that these all actually peaked at 48 hours and then started to decrease, except in the pleurectomy group, where they continued to increase up to 28 days, i.e. that even though pleurectomy is good at causing adhesions and fibrosis, that it also causes more inflammation. There have been several case reports of using fibrin glue in patients. So I just put a couple of examples here and the references at the bottom if you want to read about those cases. But it doesn't look like there have been kind of larger case series or trials looking at this. The last novel agent that I had to include, just because I had never heard of it, is looking at sericin, which I did not know what that was either. And this is a gum-like protein that comes from silkworms, actually. It helps them form their cocoon. And in this study, in 6 rats and then 6 control, they injected intrapleural sericin and then looked at parameters like fibrosis and inflammation. And you can see here that the sericin group had significantly more fibrosis than the sham thoracotomy group. So this I included just because I thought it was sort of an interesting learning point that I had not heard of. So what about TPCs? We'll sort of switch gears here. I think most of us on the call are probably really familiar with TPCs. These were introduced in the late 90s. These are silicone catheters. The distal portion goes in the pleural space. The middle part is tunneled under the skin, and then the proximal part comes out with a self-sealing valve that allows patients to drain effusions at home, which is great. Complications can be acute, meaning related to the procedure and the placement itself, although they're pretty rare. And then they can be related to the catheter more long-term, and things like infection and loculation and the catheter coming out or being blocked, which are real issues that we deal with. And I think particularly one of the things that people think of often is tunneled pleural catheter and then infection. So I wanted to address that. There's a study that came out 10 years ago now in CHEST in 2013 looking at this specifically. And it was a multi-centered retrospective review of over 1,000 cases of tunnel pleural catheter placement for malignant pleural effusion. And they were looking at rates of pleural infection. And the definition of pleural infection is as you see here. And what they found in this over 1,000 patient cohort is that slightly less than 5% ended up with some type of infection. And thankfully, 94% of these patients were able to be controlled with antibiotics. Not all of them PO outpatient. Over 60% ultimately needed IV antibiotics, but the vast majority were able to be treated with antibiotics. And interestingly, over half of the cases were managed without having to remove the tunneled pleural catheter. So I think that's really important because I get that question a lot of like, minor infection, let's take it out. And it's like, no, we can actually try and treat through this, and there's evidence to support that. And sort of an added bonus or a silver lining is that 62% of the patients ended up with post-infectious pleurodesis, which, works out well. It's not the way we want to go about it, but it's a nice side effect of it. They broke down the organisms that caused the infections, and the vast majority, and almost half, were Staph aureus, and then it was a mix of gram-negatives and other organisms. And if they did have a gram-negative infection, those were associated with higher need for antibiotics and for IV antibiotics. In this study, so that study was 2013, and I think is still very informative. In a more recent study published in 2019, this was a review and a meta-analysis looking at several different aspects of TPC versus pleurodesis for malignant pleural effusions. So they included 5 randomized controlled trials looking at this with adult patients with symptomatic malignant pleural effusion. And a few of the things that I pulled out from this are they looked at things like need for repeat pleural procedures, and they also looked at pleural infection and cellulitis. And so here you can see that on the left side, this is the favoring the tunneled pleural catheter group, and on the right side, it's the favoring the pleurodesis group. And so you can see here that the IPC group required less repeat pleural procedures than the pleurodesis group. So IPCs were better at not needing more procedures. However, on the pleural infection side and the cellulitis side, the pleurodesis group was better in that study. So TPCs compared to pleurodesis seem to have more rates of pleural infection and cellulitis. They didn't find any differences in overall survival or even dyspnea scores. They did note that there were shorter hospital stays in the tunneled pleural catheter group. So what about dyspnea outcomes and other clinical outcomes that are important to us? Tunneled pleural catheters have been around a long time, and there have been a lot of studies looking at this. The one that I'll include is a systematic review of many of these studies looking at almost 1,400 patients. And ultimately, in the many things that they looked at, they found that not only do TPCs work okay, they actually work really well at relieving dyspnea. And at least in these studies, 95% of patients had some type of symptomatic improvement, which is really important because that's why we're doing all of this in the first place. What about things like autopleurodesis? There have been several studies, and I put some of them here just to show you where they're from and when they were published, but there have been studies looking at auto or spontaneous pleurodesis with a tunneled pleural catheter, and it seems to sit somewhere around half, some closer in the 40s, some up to the 60s, and some right at 51% autopleurodesis or spontaneous pleurodesis outcomes. This concept has been explored further because it's a really nice side effect of having a tunneled pleural catheter in. So this has been studied more recently in the ASAP trial, which was published in the Blue Journal in 2017. And this was a randomized trial that took patients with tunneled pleural catheter and randomized them to either daily drainage or quote unquote aggressive drainage or every other day drainage. And their primary endpoint was autopleurodesis at 12 weeks. And you can see what they found here. This group that I have circled is the aggressive or the daily drainage arm. And you can see that the time to autopleurodesis was definitely higher than the every other day group. 47% in the aggressive, 24% in the standard, and no difference in adverse events. I think of note, 24% in the standard group is certainly lower than a lot of other series would have reported about just standard spontaneous pleurodesis, although many of those studies were not randomized. Again, in the world of sort of frequency of drainage and the desire to get dyspnea controlled in autopleurodesis, we have the AMPLE-2 trial, which was published in Lancet Respiratory in 2018. And this was also a randomized trial out of 11 centers in several countries. And they randomized patients with tunneled pleural catheters to aggressive daily drainage or now to symptom-guided drainage for 60 days. And their primary outcome was actually breathlessness or relief of breathlessness, but their secondary outcomes included rates of spontaneous pleurodesis. And here you can see that the rate of autopleurodesis, again, was significantly higher in the aggressive, the daily drainage group, 44% versus 16%. However, the symptom management, the breathlessness was no different in the aggressive or the symptom-guided drainage. So we also often talk about things like tunneled pleural catheter versus pleurodesis. And this is not talking about pleurodesis through the, this is looking at tunneled pleural catheter versus talc slurry. So this is also a randomized trial that was published over 10 years ago now in JAMA. And this is a study that was randomizing patients to tunneled pleural catheter or talc slurry through a chest tube. So this is not doing slurry through the tunneled pleural catheter. This is doing chest tube placement slurry and then, following it that way. And their primary outcome in this group, in this study, was looking at daily dyspnea. And then they had a myriad of secondary outcomes of things like complications and time in the hospital and other things that matter as well. And you can see in this trial that dyspnea scores really didn't change in the group. So whether you had just a tunneled pleural catheter or you put in a chest tube and did a talc slurry, there was no difference in the symptom management of dyspnea. However, the other outcomes that they looked at, like time in the hospital or time to discharge, time to discharge was higher in the talc slurry group. Need for further pleural procedures was higher in the talc slurry group. And autopleurodesis rates or spontaneous rates in the IPC group were 51%. They also looked at adverse events, which of course matter, and they did have a higher complication rate in the tunneled pleural catheter group, although the vast majority of them they deemed non-serious. So moving forward 5 years and in JAMA again in 2017, this trial, the AMPLE trial, was a randomized controlled trial randomizing patients to IPC or talc slurry pleurodesis. And again, this is slurry through a chest tube. This is not tunneled pleural catheter and slurry through the catheter. And their primary endpoint was total number of hospital days for both procedure. And then again, secondary endpoints like breathlessness and adverse events, et cetera. And what they found here was that hospital stay was longer in the talc pleurodesis group. effusion-related hospital stay, longer in the talc pleurodesis group. And then further pleural procedures required were higher in the talc pleurodesis group. So these are still very similar findings to the other studies. They looked at adverse events, of course, and you can see they had overall adverse events, which were higher in the TPC group. But when they stratified them into serious adverse events, there was no statistically significant difference, but there were 3 in the talc group and 1 in the TPC group. So overall, they found that TPCs decreased hospital stay, they led to fewer additional procedures, but again, the adverse event rate and typically minor adverse event rate is higher than talc pleurodesis. So that brings us to, well, hey, what about doing both things? You know, why does it have to be tunnel pleural catheter or chest tube and slurry or thoracoscopy and poudrage? What if we combine the two? And that has certainly been done. What is named sort of the rapid pleurodesis protocol, although people can mean different things by saying this, what I mean here is that you do a thoracoscopy, you drain all the pleural fluid, you take down adhesions, which I think is an important part of this, insufflate talc, put in a tunnel pleural catheter plus minus another chest tube, and then manage the patient and ultimately send them home with the goal of achieving pleurodesis. The initial studies looking at this were published in 2011, and it's Chalk Reddy and Eric Folk both published their series looking at this. And the important outcomes that they looked at were length of hospital stay. So now this is only 1 or 2 days following this rapid pleurodesis protocol. So this isn't the 4 days that we're seeing in these sort of chest tube talc slurry groups. And they looked at length of catheter placement, meaning the tunnel pleural catheter that they placed at the time of the procedure. And that averaged between 7 and 16 days that you were able to remove that after the rapid pleurodesis. More recently, there have been larger case series, although no, larger trials or randomized trials in this. But in 2019 and in 2021, we have series that are published with similar outcomes. In the most recent trial, which was published 2 years ago, 86.7% of patients were discharged the day of the procedure, which is great. And the length of the catheter, the TPC placement, was similar to the other studies, between 10 days and 20 days of being able to remove the catheter. We can also do pleurodesis through the tunneled pleural catheter itself. So the difference here being that you're not doing a thoracoscopy, you're not taking down adhesions if they're there, but you're also not having somebody, undergoing a moderate sedation procedure. You're putting in a tunneled pleural catheter and then you're pleurodesing through that. And this was actually published in the New England Journal in 2018, which is awesome. They looked at patients over 4 years. There were 18 centers out of the UK, and here everyone had a tunnel pleural catheter in. They had regular outpatient drainage, and as long as they didn't have trapped lung, they were randomized to either talc or nothing, placebo. And they followed them, up to 70 days, and the primary outcome was successful pleurodesis. And you can see here, this blue line is that the talc group, the group randomized to talc, had a significantly higher pleurodesis rate at 35 days and at 70 days. And you can see the numbers here. So 43 compared to 23 at 35 days and 51 compared to 27 at day 70. And there were no differences in the adverse events. So their conclusion was that outpatient talc via IPC has a significantly higher chance of pleurodesis than IPC alone, and there's no drawbacks. So what about cost effectiveness and how does cost play into all of this? And there have been several cost studies looking at this. This is a study published in Chest in 2014 based off of data acquired from the Time 2 trial. And they looked at costs associated with the initial procedure and then ongoing costs thereafter. And you can see here that when they broke it down in costs for IPC versus talc, the cutoff point here where IPC was favored, meaning less expensive, was about 14 weeks of life. So if the patient was only going to live less than 14 weeks, then the IPC had a higher cost effectiveness or a lower total cost than the talc group. Otherwise, in general, they found no differences in the initial procedure, but in the subsequent management, if the patient has limited survival, the TPC was less costly. This was sort of piggybacked on, this is the same group actually using the same data set of the time 2 data that then published a few years later in respirology, this time looking at quality adjusted life years and ECR, and looking at direct healthcare related costs. So not patient time and travel and those things, but direct healthcare related costs. And this is a very busy table, so I just put these red boxes to focus in on, overall total costs or quality of life years gained. There was actually no difference. However, again, when they looked at, survival being less than 14 weeks, they found that the IPC was more cost effective than the Pleurodesis group. However, if 2 hours a week of nursing or more was required, then actually the TALC group became more cost effective after 14 weeks. If the patient had a survival of less than 14 weeks but had a higher nursing requirement, then there was no difference. So I think it added a layer in there about quality adjusted life years and about nursing care to help us sort of stratify what in a cost effective way may make more sense. Finally, and I really like this study, this was published by Majid Shafiq and his group in 2020, using a decision tree model with these theoretical event data that was derived from the ASAP trial and the AMPLE-2 and IPC+. And they looked at IPC drainage strategies and whether they were cost effective or not. So this is everyone has an IPC and they're either having symptom guided drainage, daily drainage, or IPC plus TALC. And they put out these sort of theoretical models playing out in each group if they achieved pleurodesis or not. And then each of those groups, if they had a complication or not, based off of published rates of both of these things. And ultimately, what they found is that in what I have circled in the box here, the daily drainage group, which is the triangle at the top, as well as the IPC plus TALC group, which is the red square, were more effective than symptom guided drainage. However, at the bottom here, which is the cost portion, symptom guided drainage and IPC plus TALC were way more cost effective than daily drainage. So ultimately, their conclusion from this is that even though more data, more studies are necessary, that the sweet spot may be IPC plus TALC from a cost and a cost effectiveness perspective. However, they did find when they modeled this out that if someone's life expectancy was low, meaning less than 4 months, or if the likelihood of pleurodesis was greater than 20%, that maybe symptom guided drainage made more cost effective sense. So finally, prognosis, because a lot of what we talk about with cost effectiveness has to do with how long is someone going to be alive, which of course no one actually knows the answer to. And so there have been many scoring systems looking at prognosis trying to help us answer this question. And I think one of the most widely known one is the Lent score, which was published in Thorax in 2014. And this was a prospective study out of the UK, Australia, and the Netherlands. They followed patients up to a year or until death with malignant pleural effusions. And they looked at a variety of indicators to see what would predict survival. And ultimately what they landed on was here, which is the LENT of the Lent score, LDH, ECOG, the neutrophil to lymphocyte ratio, and then the tumor type. And when they have stratified these patients then into low, moderate, and high risk, they actually correlated this with survival. So you can see here that the best survival was in the low risk group and the worst survival was in the high risk group. And I think this is one of the more widely known scoring systems. So more recently, there have been, of course, efforts to try and help kind of hone this in. And this study that was published in Respiration in 2018 actually looked at the Lent score in a selected patient population of patients with lung adenocarcinoma. Because the Lent score stratifies by tumor type widely, but when we're talking about, more specific types of lung adenocarcinoma, which we know may have better survival, the Lent score doesn't account for that. So this was a retrospective review of 70 patients, all with lung adenocarcinoma, with about half who received TKIs. And they looked at the Lent scores for each of these groups, and then they looked at a modified score, meaning that they only gave they gave 2 points to anyone who did not have a mutation, and they gave 0 points, meaning a lower score, if you had lung adenocarcinoma with an EGFR mutation. And here you can see that in the original Lent score, the scores are the same, whether you're treated with TKIs or just with standard chemotherapy. In a Lent score world, these patients have the same prognosis. However, when you look at actual survival in these groups, you see that patients treated with TKIs have a longer survival than those treated with chemotherapy, which we know happens with adenocarcinoma. And so when they applied their modified score, just adjusting that tumor type, they took the current study, meaning that the current Lent score, and then applied their modified Lent score, and actually found that this correlated much more with survival. And so their conclusion was that if you just modify that tumor type for adenocarcinoma with a mutation, then that improves its accuracy for this cohort of patients. In that same year, in 2018, the PROMISE score came out and was published in Lancet Oncology. And this looked at 5 big data sets and looked at clinical, radiological, and biological variables and ran various models on this. And then ultimately they compared it to Lent to see how they did. And they devised a clinical PROMISE score, which you can see here, and a biological PROMISE score, which is the clinical score with the addition of a pleural biochemical marker, which you can see here. And ultimately, you can see that when they applied the Lent score to their population, compared to the clinical PROMISE score and the biological PROMISE score, that the PROMISE scores seem to have much better separation of patients into actual survival. And so their conclusion was that the PROMISE score is the first prospectively validated model combining biological and clinical parameters to accurately estimate 3-month mortality. Of course, the big caveat here is that if you're using the biological model, you have to send a biomarker from pleural fluid, which may not make it as clinically relevant, although they do have the clinical score, which stacked up pretty well against the Lent as well. And then finally, in 2021, we have a retrospective review of patients with non-small cell lung cancer, looking at whether squamous type or adenocarcinoma type made a difference. And they looked at yield and they looked at survival. And you can see here that the pleural fluid yield of adenocarcinoma was significantly higher than squamous cell. And you can see actually that survival after first thoracentesis was higher in the adeno group than the squamous group, ultimately concluding that pleural fluid cytology is worse in the squamous cell group, and that patients with a pleural effusion with squamous cell do worse than those with lung adenocarcinoma and a pleural effusion. So I'll end with the last few slides, coming back to what I think still is the most important part of all of this, because I've given you a ton of data and a ton of outcomes and numbers and all of these things. And at the end of the day, I think it comes back to, what about the patient? Do they want this tunneled pleural catheter of some type? Or do they want this, which is a post-thoracoscopy patient? And what I hear a lot when I talk to patients about both things, so I have some patients that say, I don't want to go to the hospital at all. I want to be home. I don't want the risk of having multiple procedures, and I don't want to be in pain, even for a day. I don't want to wake up post-op and be in pain. On the other side, I hear patients, and I'm in Southern California, and this may sound silly, but it's a very real thing, of patients who say, swimming is my life, surfing, taking baths, water sports is my life. How am I going to do this with an indwelling catheter? I've had patients that say a catheter is constantly going to remind me that I have cancer. And I have patients who say, I have no one here to help me take care of it. And I'm remiss here because I meant to insert a slide about education for TPCs. Our NP, Shana Race, is the most wonderful woman in the world, because she has revamped our clinical care of patients with TPCs. A lot of education needs to go into this when you're discharging someone with a tunneled pleural catheter. So I'm remiss that I didn't put that slide in. But at the end, returning to this algorithm that I started with in the beginning, which is sort of, a workflow of how I think about these things. At the end of the day, this is at the center: discussion of goals, risks, benefits with the patients. And now after this talk, I think we've gone through the things that inform that discussion. Do they have a trapped lung or not? What type of tumor do they have? What are their prognostic scores? How long are they going to live? If you think they're going to live a week or two, I don't want to take that patient for a thoracoscopy. What are the hospitalization rates and the complications, and what does that patient want? If they don't want to be in the hospital at all, again, I'm not taking them for a thoracoscopy. At the end of the day, it's what do they want for their life? What's important to them that then combined with the data and outcomes that we know that I use to have that informed discussion. And so my conclusion overall is that even though there are advances in targeted therapy, we absolutely have to stay on top of these malignant effusions, and that early intervention is probably better. If you need more tissue, consider thoracoscopy, because you can do the pleural biopsy and then just leave a tunnel pleural catheter. If you have a trapped lung, you can consider pleurodesis. If you don't have a trapped lung, you can do multiple options, but it's two things at the same time. Overall, there is no difference in talc poudrage versus slurry. The only thing we always talk about is that, and I don't think the studies have evaluated this really well, is that sometimes you go into these pleural spaces and there are just tons of adhesions that you end up taking down when you're doing the thoracoscopy and then doing the poudrage. And so I still wonder that if you factored in a significant amount of adhesions and the ability to remove them and have an expandable lung, would that make a difference? But the studies show so far no difference in poudrage versus slurry. There are novel agents that are being looked at, so we'll look forward to seeing how those go. Tunnel pleural catheters are, I put good options, they're great options for symptom control. And they also mean less time in the hospital, fewer subsequent procedures compared to pleurodesis. Daily drainage has a higher rate of autopleurodesis, but it's much more expensive. So as we're looking at costs, we have to take that into consideration. And that really maybe tunnel pleural catheter and slurry is the sweet spot for all things, as long as there's no trapped lung. And at the end of the day, the most important thing is to just have an informed discussion with your patient and see what it is that they want. So with that, I will stop and take questions.
I must say, Catherine, this is Hasnain here. A very, hi, can you hear me?
Yes, great.
This was an exhaustive review of literature, and thank you for the wonderful talk.
Hopefully not exhaustive in a bad way. So
No,
there's a lot of information.
It was very detailed and a very thorough review. And I must confess that it was the first time I heard of the word sericin from silkworms as well.
Thank goodness it's not just me. I was thinking, what in the world is this? So I had to include it just in case there was somebody else out there.
Absolutely. I just have a couple of questions here. And one of the questions here from the audience is, what has your practice been at your institute? Do you do outpatient TPC, or do you do TPC plus talc slurry, and those who are not thoracoscopic candidates?
We do it all. I just find that that's why I always give those caveats with that sort of algorithmic workflow, is that I feel like I have so many different patients who want different things. Sometimes even when I talk to patients about tunnel pleural catheter and then, hey, why don't we do slurry through this? You know, you have an expandable lung, you'll do great. And they just say like, I don't want that. I'm not interested. My catheter works well. I don't want to risk having any pain. None of those things. So I like having all options available. And when I'm approaching a patient, I sort of look at all the things that I think are probably gonna be relevant and come up in my mind with what I think makes sense with, you know, their treatment course and probably their projected survival. And then I talk to them and sort of have that in the back of my mind of what I think may make the most sense. And then I hear what they're saying. And if it's totally contradictory, if they're saying, I will not have a catheter, I will take any shot I can have of only having a catheter for a few days or a few weeks, you know, take me to pleurodesis, that, you know, poudrage, pleurodesis, whatever, then we do it. So I don't know, I do both is the short answer.
Kind of what summed up in your last slide, where you said quality of life, and for people, it's a constant reminder, so they would want their TPC out.
Yeah, totally. I get those patients often that say like, no way, I'll be in the hospital for as many days as I need if we can limit the amount of time that I have this thing in. So, you know, if it makes sense, then we go for it.
I got another question here, Catherine. It says, how do you incorporate the prognostic scores in determining which option's better, TPC versus pleurodesis?
It's such a great question. And I feel like every time I talk about this with anyone and everyone, we talk
Right.
about these things and they're validated and they're wonderful and look at this. And then we all sort of look at each other and say, do you guys do this regularly? Are you calculating these scores regularly? And the answer is usually no. So I think it may be a call for us to do this more. That I think that's highly possible. I feel like I get a good sense often when I'm talking to patients about with their cancer, how it's going, what treatment options they have available, are there trials available, how are those trials going, and their sort of general level of frailty, which I think helps inform my decisions. But, I don't use those scores often, and maybe I should. So, because they are objective measures and they have been validated.
And that's so true, because I was always taught during my fellowship to calculate the length score. And very rarely did we ever use the promise score. I don't know about you, if you guys use the promise score even.
I have sort of out of my own academic interest in some patients done both to sort of see how they worked. I've only done the clinical promise. I have not done the biological promise. So I think it works well if you have all of that data and you take the time to do it. I haven't noticed that it's been a game changer or that it's told me something that I didn't already think was probably the case. But relying on just what you think and not data is fraught with problems. So this is probably, every time I have this conversation, I tell myself, you know what, you should just get in the habit of doing it every time. So.
True. I'm so sorry. The questions keep coming. It was such a great talk. Oh, when will you consider IPC for cytology negative pleural fluid?
I guess for cytology negative, you have and I guess the question is like, if you have a really strong suspicion that it's malignant.
Right. Yeah. In relation to malignant carcinoma, recurrent TAPs have yielded nothing.
Yeah. That also is a conversation that I have with a patient. And I guess it sort of depends on their clinical scenario of, are the oncologists really pushing for a diagnosis in tissue? Because it may actually make a difference about what trials they can be enrolled in and this and that and the other. If that's sort of the scenario, then oftentimes I'm sort of leaning away from TPC and talking to them about that. If they say like, I don't care, I don't want to be in a trial, or if there are no trial options, or then I think TPC is a good option. And again, when I think cytology negative, like getting a very academically a diagnosis just is not always practical, and it isn't always in the patient's best interest. So I think if there's a real reason to push for diagnosis, then maybe you do that. But if you have a strong suspicion that it's malignant and the patient wants to go home, and I'll put in a TPC and follow them, and we'll go from there.
True. And again, that same caveat that how many times do you actually see a positive diagnostic yield on cytology?
Yeah, I mean, it's not great. Our big thing is sort of when somebody's had like a 9th thora that's been, lymphocytic exudative and negative, and everyone's wondering because clinically it matters what the diagnosis in. Those patients I really like to take to thoracoscopy because our patients do really well. It's moderate sedation. It's like a glorified chest tube in a way. It's spontaneous ventilation. They're not having a double lumen tube. You just pop a scope in there, take the fluid out, take the biopsies, and then get an answer that might actually inform their clinical care. So those scenarios I hate when somebody comes to me and you're like, you've had 700 thoras, what's going on here? But I also think, you don't have to always go for a diagnosis just because, you do it when it makes sense.
One last question from the audience. Do we have any outpatient follow-up protocols or any websites that would guide us if we were to institute an IPC program?
Oh my gosh. It's funny you mentioned that because we sort of do our own internal thing, but I was just looking at, because again, I meant to put this education slide in because it matters so much, the outpatient management. So as I was going through this, I was just looking online and saw other programs that actually publish their like post TBC care. And I think it's like MSK, and there were several on there online. And I was like, wow, this is amazing that they put all of this online. So I think if you Google it, it's probably there. But whoever asked that question, if you send me an email, I can send you what I have, either from just our institution and then what I found when I was looking at this. But there's a wealth of institutions who so kindly put this online, which is great because it really matters.
Fantastic. I have no more questions here, Catherine. I want to thank the audience for being such an awesome audience and wonderful questions. Really good questions here. And more so, thank you for this talk once again.
Oh yeah, thanks for having me. It's been a lot of fun.
Thank you once again, guys. Thanks, Catherine. Have a good evening.
Thank you. Bye-bye.
Bye-bye.